Is it safe to use braces in children? This is the controversy we are going to discuss today. I want to go over all the details about whether it is safe. If not, what the dangers are, but what precautions you should take before placing a single bracket on a mixed dentition patient. So stay with me in the video. You will enjoy all the guidelines. Welcome to another class, another video from this channel. Today we are going to talk about braces in children, also called technique 2x4, which is a technique that, contrary to what people think, is not just a trend where people started to stick or cement braces on children for non-scientific reasons. No, my dear ones, we find records in the literature, and I tell you that there are not many, such as mandibular expansion, where we find more than 80 systematic reviews in the scientific literature. However, we do not find many articles on technique 2x4, but in a recent search I conducted, I found about 25 or so quality articles regarding technique 2x4. For you to know a little bit about the history, the first time this technique was used, it was created by Dr. Tom Mulligan. So it was the first time the technique called 4x2 was used, because there are 4 brackets in the anterior region and 2 accessories in the posterior region. You know that the first bracket was created by Dr. Angle, and this accessory was for corrective orthodontics. It was for adults. First bracket, the edgewise bracket, the most classic of all, had no information on the base of the bracket. There was no inclination, no torque. There was no information at all on the base of the bracket. But later, when there was already a history in collective orthodontics, Dr. Tom Mulligan ended up applying this technique in children patients in mixed dentition for different applications. And then Dr. Isaacson was the one who named and officially recognized this technique for the first time. At that time, this term was criticized in the Angle Orthodontists, which is the largest journal in the world. Doctors from the University of Pennsylvania sent critiques, saying that the term 4x2 is actually called 2x4 in English, but they began to criticize that this term 4x2 was not a good term to define the technique, and it ended up remaining as 4x2. This revolt from the doctors did not advance anything. Well, from the moment we had this technique, the doctors began to apply the technique, and it turned out that we started a big problem. Why? Because they began to apply the same bonding technique for brackets for corrective orthodontics to preventive orthodontics. But there are details in the child who is developing occlusion that if we do not pay close attention, 4x2 can be the most dangerous treatment with the most effects we can have in preventive orthodontics. So, the answer, I already hint a bit at the answer about whether it is safe to apply braces in children. It can be safe, but it can also be unsafe if you do not apply the concepts properly. And the greatest danger involved in placing braces on children is the resorption of the lateral incisor, the resorption of the root of the lateral incisor. Because basically, if you apply the bonding technique, what would it be? The center of the tooth, on the axis of the tooth, in the center, in the mesiodistal direction, evaluating the proper angulation of this crown. If we simply bond this bracket on this lateral incisor, the lateral, when correcting its angulation, will come into contact with the crown of the canine, and this contact can generate external resorption in the root of this lateral incisor. With me, it obviously never happened because I apply the proper technique, but I have seen colleagues who receive patients in the office with lateral incisors simply lost, meaning extraction, because a doctor applied technique 2x4 inadequately. Imagine a child with a lateral incisor lost because of that, and that is why it is one of the most dangerous techniques. It is safe, but it must be done the right way. Okay. Basically, my dear ones, we use technique 2x4 for a portion of indications. It ends up being a very versatile technique. We use them for closing diastemas, when it compromises aesthetics or function in speech. We use it for issues associated with sucking habits and interposition. We use it for traction of impacted incisors. We use it for poor positions that cause psychosocial impacts, so sometimes the patient is not happy with their appearance, and that ends up having psychosocial effects. We use it for the correction of pseudoclass 3, for protrusion of incisors with labial interposition. We also use it as a space maintainer, which is an indication that I personally do not like, but it is used for many factors. And that is why I want to share 3 tips in this video for you who are a beginner or for you who are already experienced but they didn't tell you. I am here to say, okay, first of all, you cannot apply the same technique you use for corrective orthodontics to interceptive orthodontics. As I already told you, there are specific characteristics in this lateral. This lateral, when it is in the phase of pachetofeo, is mesoangulated. And why is it mesoangulated? Because the pressure from the eruption of the permanent canine causes this mesoangulation of the laterals and the opening of diastemas in it between the central incisors. So we have the interincisal diastema and this mesoangulation of the roots and distoangulation of the crowns. If I simply place the bracket on the axis of the tooth, I will have this enormous risk and this iatrogenesis of external root resorption external to the lateral incisor. So basically, what do you have to do? You have to do a passive cementation of this bracket. The arch must passively go through. So we do not have to make any correction to the angulation of this tooth. We can only do leveling or a slight correction of angulation, but always maintaining this mesoangulation of the root and this 2009 distoangulation of the crown to avoid this risk. So, this is the first tip. The second tip that I can give you is that this treatment is a targeted treatment. This treatment is not a 1-year treatment, it is a 6-month treatment, my dears. So, look here. Be quick. It's the second piece of advice. Be quick. Here, for example, in this archiclook that was made by this group of Italians, the versatility of this appliance allows for solving different problems, and it is for a short treatment period, about 6 months. So, approximately 6 months of treatment. If it is lasting much longer than 8 months, there is some problem, so be quick. And also here within this same article, they studied 200 doctors, with half being orthodontists and half being general dentists. And what they evaluated is that general dentists also have knowledge of the technique. Look here. They concluded in the article that the knowledge of the use of 2x4, which would be 4x2 in our Latin American language, is quite widespread among orthodontists, 93-94%, and about half of general dentists. And what they conclude in the study is that they believe that the 4x2 is a valid option for interceptive orthodontics in the dissemination of orthodontic specialists, but also among general dentists. So, if you are a general dentist, you can and should study more about the technique. Even the scientific literature is already discussing it here. Look, general dentists, orthodontists, you study the correct technique because it is so important that when the child arrives at your office, they must go through a diagnosis. And preventive interceptive orthodontic treatment, I take this opportunity to tell you that inside the interceptive diploma, which is my diploma, which is about preventive interceptive orthodontics, there is a module with many clinical cases and a detailed explanation of everything I am discussing in our module number 4. The interceptive diploma is a diploma that ultimately becomes a method. My students, who are wonderful, are already applying the knowledge because we go from the origin of the problems to the diagnosis, protocols of all treatments within preventive interceptive orthodontics. At this moment, we do not have open registrations, but I will leave the pre-registration link here because I always send all the information in advance to those who are pre-registered and also provide special conditions. So I leave it here for you. Continuing with our third piece of advice, here for the cases you are handling with a treatment using technique X, it is necessary to be very careful at the time of removing these brackets. Why? Because the removal of the brackets must be careful in corrective orthodontics. Now imagine in interceptive orthodontics, the treatments with 4x2 in dear children, we have to condition this enamel with acid, then apply the entire bungee part, then the resin. And I tell you, we must spend these 6 months with these brackets with a lot of control over bacterial plaque to avoid white spots. And we must go unnoticed. What I always talk about, you should not perceive that this boy wore braces in his life, and we only go unnoticed with that treatment. If we take care during the removal stage of this appliance, it turns out that this child will probably have to undergo another treatment with braces, which would be the corrective phase, at the time of reconditioning this enamel. This tooth must be preserved, completely preserved. For that, always look for burrs and equipment and everything for the proper removal of these brackets. So you are going to use a bracket removal pliers very carefully for the love of God. First of all, a specific resin for orthodontics. You cannot use resin that is not for orthodontics because they have different loads. And the resins for orthodontics are made to not be permanent like a restoration resin. They are made to be removed without fracturing the enamel. First of all, a good resin indicated for orthodontics. Then you will need a bracket removal pliers. Be careful in this process. And finally, you will have to remove this resin from the base of the enamel. For that, use the burrs, especially the laminated burrs. It is interesting that you always look for different burrs. Burrs from orthometric, from Reliancy, or burrs that have dental or aesthetic brands, but that do not wear down the enamel of the tooth. And I also like to start the removal of these resins with one that can be high speed because it ends up being more practical in the office. The studies end up saying that low speed burrs, also with water the same, without being in a dry environment, is the best of the best options. But for practical reasons, high-speed ones end up being more used, as long as they are specific for this environment. And the final part of the removal of this bracket, it is interesting that you use USEN rubber bands, those specific rubber bands, because this way there will be no risk of enamel demineralization for this patient. Special care that is for you. We saw here then, my dear ones, that it is indeed safe to use brackets on children as long as we know the effects of everything that can happen with this patient. That there are real and dangerous risks, but if the proper technique is being used with responsibility, everything is fine, it is safe and very well used. We also saw here that the passive segmentation of the brackets is very important, that it is important to be quick over that time, not to exceed 8 months of treatment, and that there is care when it comes to removal. I hope you enjoyed this video. See you in the next class next week. Don't forget to subscribe to the channel to receive the next notifications and leave a like on this video. A big kiss and see you next time. Bye.